Good morning, ladies and gentlemen. I'm Professor Seung from Catholic University of Korea. Today, we'd like to have a first seminar, symposium, for the opportunization one. The title would be Challenges and Strategies for the Better Laparoscopic Gastrectomy for Gastric Cancer. Today, I'd like to have a co-chair, Professor Seung from Keimyung University. Professor Liu.
Hi. Good morning.
Yeah. I'd like to moderate for the first two presentations, and Professor Liu will co-chair for the last two presentations. We invited 4 precious speakers from Korea, Japan, and China. The first speaker is Professor Han-Hong Lee. Professor Han-Hong Lee graduated from Catholic University of Korea, and now he is working as a professor and Department of Surgery, Seoul Saint Hospital. He will talk about the reduced port surgery for gastric cancer. Professor Lee, please.
Good morning, ladies and gentlemen. I'm Han-Hong Lee from Seoul St. Mary Hospital, the Catholic University of Korea. I would like to talk about reduced port surgery in treatment of gastric cancer. For more than 20 years, most laparoscopic gastrectomy is being performed with the 5-port technique with or without mini laparotomy. Actually, most gastric cancer surgeons may not feel the necessity of reduced port surgery in treatment of gastric cancer. So, why do we perform the reduced port surgery even in gastric cancer operation? First reason is increasing shortage of operation team in major surgery. Also, Korean resident training system is reduced to 3 years. Second reason is surgeons' challenging mind. Most surgeons tend to try to invent a new technique and device. Reduced port surgery in gastric cancer treatment means the operation using less than 4 ports except single port surgery. I do not think the reduced port surgery is not a middle stage from conventional laparoscopic surgery to single port surgery. In fact, the characteristics of reduced port surgery is quite different from single port surgery. To do single port surgery, we have to use multi-channel trocar, and the conflict between instruments may happen, and OP team is struggling with a limited visual field and confined space. Also, single port surgery is being performed in only treatment of early gastric cancer. On the contrary, reduced port surgery is performed with regular trocar, and there is no conflict between instrument and between persons. Special device is not required in reduced port surgery. And most of all, reduced port surgery can be performed in most various cancer status. In 2016, I published my first article about reduced port surgery in treatment of gastric cancer. There are no differences for short-term outcome between reduced port and 5-port group. Moreover, reduced port group had faster plateau time. So, I conclude that reduced port laparoscopic gastrectomy is a reliable scar reducing method with good operative and short-term outcomes for the treatment of gastric cancer compared with conventional laparoscopic gastrectomy. Interestingly, meta-analysis article for reduced port surgery is published in 2020 that has same title with my first article. The paper concludes that reduced port gastrectomy is as safe as the conventional laparoscopic gastrectomy approach and offers better aesthetic result for patients with gastric cancer. This table shows settings of reduced port gastrectomy according to the number of trocar. I think these two types of gastrectomies using 3 or 2 port are practical reduced port surgery. Except scopist, assistant is not needed in 3 or 2-port gastrectomy, and rigid scope can be used in this rigid port gastrectomy, unlikely single-port surgery. Duet means 2 persons, operator and scopist. Duet gastrectomy is a kind of the rigid port surgery using 3 or 2 ports performed by 2 persons. Duet gastrectomy has all same advantage of rigid port surgery. These 3 surgeons are major duet gastrectomy surgeons in Korea. They published most of articles about duet gastrectomy. And these are results of those articles. This graph shows learning curve of duet gastrectomy using operative time. Learning curve time is not long in both of 2 studies. These figures show the comparison of number of retrieved lymph nodes between duet and conventional laparoscopic gastrectomy. There are no differences in both of 2 studies. Various reconstruction can be performed using reduced port. This is my published article about uncut 1Y reconstruction in reduced port surgery. My figures decorated cover picture in such issue. This is another report for uncut 1Y reconstruction, published in the 2020. Also used 2-port and left side approach. As you know, regarding cancer surgery, long-term outcome is most important thing. This is first article about long-term survival of reduced port surgery, published by Japanese doctor. This is single-center retrospective study, and total number of patients is 274. Reduced port surgery is performed with 1 multi-channel port and 1 regular port. This study included subtotal and total gastrectomy. Operation time is relatively long in reduced port surgery, but blood loss is higher in conventional group. The number of retrieved lymph nodes is similar in both groups. There are no differences for overall survival between reduced port and conventional port group in respect of extent of resection. Also summarize that reduced port gastrectomy for gastric cancer is a feasible and safe technique when performed by an experienced laparoscopic gastric surgeon, and that reduced port gastrectomy can be considered as an effective treatment option. And this is our article published in this year. The data of 3 major Korean surgeons using 3-port is collected, and long-term survival is reporting in this our article. Only subtotal gastrectomy is included in this study, comprised of the data of the 3 major institutions: Seoul St. Mary Hospital, Jeonnam Hwasun National Hospital, and Samsung Medical Center. We used only regular trocar. 1,131 patients were enrolled in this study. Of them, 460 patients underwent 3-port distal gastrectomy. Body mass index was a little bit high in reduced port group, but except that there are no differences regarding various characteristics between 2 groups. Short-term outcomes, including operative details and morbidity, were similar in both groups. The long-term survival did not differ in both groups. In stage 1 and advanced stages, there were no differences in the disease-free and overall survival, respectively. This forest plot shows hazard ratio of 3-port gastrectomy in subgroup with different factors. There are no significant differences between 2 groups. To summarize of our study, this large multi-institutional study demonstrates that long-term oncological outcomes of 3-port laparoscopic gastrectomy were comparable to those of conventional 5-port laparoscopic gastrectomy in patients with early-stage gastric carcinoma. And 3-port laparoscopic gastrectomy may be an appropriate option to perform laparoscopic gastrectomy without a surgical assistant, without increasing the risk of the patient. And large randomized clinical trials are warranted to determine the clinical benefits of 3-port laparoscopic gastrectomy in treating gastric carcinoma. So, we are planning a randomized controlled trial for reduced port gastrectomy. We received the class trial number 12. In conclusion, reduced port surgery is a safe approach and has no limitation of operative technique compared with conventional laparoscopic surgery. And long-term oncological outcomes of reduced port gastrectomy might be comparable to those of conventional 5-port gastrectomy in early gastric cancer. Randomized controlled clinical trials will be conducted in order to clarify the feasibility of reduced port surgery in gastric cancer. Thank you for kind attention.
Thank you for this presentation, Professor Lee. We don't have a question from the audience, but I have one question. Probably the final destination of this effort would be a single port surgery, I guess. So what do you think that we should have to progress to do the single port surgery, such as SP robotic system would be helpful, or what advances are needed to do a safe operation with the single port surgery?
Good morning, Professor Liu and Professor Seung. That is very difficult question. So because of the I have no experience about the single port surgery, but as you mentioned before, the single port surgery and the reduced port surgery, I think that is the separate thing. So, but the I think single port surgery is very single port surgery is I think that's the more difficult than the reduced port surgery. So I have the few experience about the single port surgery using the Da Vinci system XP. So but that is the patient who underwent the single port surgery by me, that a little bit thin, and so that is just the early gastric cancer. So but what we should do the single port surgery using the new technique of the robotic system. So it's a very difficult question because
I meant that the effort to do a reduced port surgery would be by the surgeon's effort. So I think that some progress in instrument or system would be helpful to progress this type of effort. So you can do freely or safely the reduced port surgery, but if something new is progressed or developed, especially for the instrument, it would be more helpful, I guess. And probably you can do a single port surgery very safely and easily in the near future. So we need to do something to develop that type of instrument or technique, I meant.
I totally agree with Professor Song, but I think the single port surgery, as mentioned before before the slide, I think reduced port surgery is not the middle stage of to go the single port surgery. So, but with the but if we have the new technique, and so the progress technique about the single port surgery, so if we can do the single port surgery easily by that technique, so I will do that. I can do that. So I have to have to do, I think so. But in this current technique system, that I think that is to do the single port surgery is very difficult. So but this robotic system is little bit the higher technique compared with the laparoscopic technique. So I think that I have to get the more experience about the single port surgery. Robotic surgery with the new technique. So I totally agree. But I think that I have no idea about the single port surgery. Using the more advanced technique of this reduced port surgery. So that is my future job. Okay.
Right. Professor Liu, any comments or questions to Professor Lee?
Yes, thank you very much. Your informative lectures. I have one simple question. Is there any difference between the learning curve of the reduced port surgery or the basic skills of laparoscopic surgery? How about you in your situation?
Actually, the learning curve about the reduced port surgery really be long compared with the conventional laparoscopic surgery. I think what is the in fact, we are progressing. We are we are doing about the class 12 the class 12. So we are doing currently the video workshop and with the committee member. But that committee member is a little bit the experienced surgeon. So what I want to talking about the reduced port surgery is not the learning curve for the experienced surgeon like you and like Dr. Seung and Dr. Sun. So we are the Korean doctors has a good hand. So if we Korean gastric surgeons try to do the reduced port surgery, I think that they will have the little bit short the learning curve. I think.
Okay, thank you.
All right. The next speaker would have a talk for the single port surgery. So it would be helpful to compare that. Okay, thank you, Professor Lee. And I'd like to introduce second speaker from Japan. The name is Takeshi Omori. He's a very famous surgeon even in Korea. He graduated Osaka University Graduate School of Medicine, and then now he is working as a director of Gastric Cancer Division, Osaka International Cancer Institute. He'll talk about the single port gastrectomy for gastric cancer. Dr. Omori, please.
Good morning, everyone. My name is Takeshi Omori from Osaka International Cancer Institute. It is my pleasure to have an opportunity to make my presentation here. Today, I'd like to talk about single port robotic gastrectomy for gastric cancer. This slide shows a picture of our new hospital. In March 2017, the Osaka International Cancer Institute was relocated and rebuilt just in front of Osaka Castle. We mainly perform minimally invasive surgery for the treatment of gastric cancer and have been performing single incision gastrectomy for advanced meats since 2009. We have performed 500 single incision laparoscopic gastrectomies. Recently, we have performed 400 cases of robotic gastrectomy using the Da Vinci surgical system. In recent years, more than 90% of gastrectomy for gastric cancer, adenocarcinoma of esophagogastric junction, has been performed by minimally invasive surgery. We have performed laparoscopic or robotic gastrectomy in 98% of gastric cancer patients last year. The first robotic gastrectomy was performed at our hospital in 2014. In Japan, robotic gastrectomy for gastric cancer was covered by the National Health Insurance in April 2018. The rate of robotic gastrectomy has been increasing year by year. We have performed 160 robotic gastrectomies last year. Minimally invasive surgery, including laparoscopic and robotic gastrectomy, has provided a new alternative surgical approach to treating gastric cancer. The introduction of laparoscopic surgery has significantly improved gastric cancer surgery, such as less blood loss, faster recovery, less pain, and shorter postoperative hospitalization than the open approach, with comparable morbidity and long-term outcomes. However, laparoscopic surgery has significant drawbacks such as limited range of motion, amplified hand tremors, and inconvenient surgical positions. Therefore, laparoscopic gastrectomy took significantly longer than the open approaches. In fact, some studies have shown that laparoscopic gastrectomy has a high frequency of postoperative complications such as pancreatic fistulas than the open gastrectomy in the real-world data. The pancreatic fistula is thought to be caused by the compression of the pancreas and the heat injury by energy devices. What is the key to reducing these complications? Another minimally invasive procedure, robotic gastrectomy, is increasingly being performed, and many clinical trials have shown it to be as safe as laparoscopic gastrectomy in the treatment of gastric cancer. This procedure has been reported to overcome the innate limitation of conventional laparoscopic surgery. It offers new features such as full tumor filtering, 3D stereoscopic HD view with magnification, 7 degrees of freedom measurement, short learning curve, and increased surgeon dexterity when fine manipulation is required. The double bipolar method was introduced by Professor Ullman, in which the first arm is used with fence-rated bipolar forceps in soft bipolar, and the third arm is used with Maryland forceps in bipolar cut mode. We have modified this technique and named the double soft bipolar method with the first and the third arm in the bipolar soft mode in robotic gastrectomy. The modified procedure has the advantage of providing a dry and clear surgical field due to the tightly sealed blood vessels and lymphatic ducts. This short video shows the double soft bipolar technique in number 1 and 3 lymph node dissection. Usually, the first arm uses a fence-rated bipolar forceps in soft bipolar mode, but in this case, the first arm uses a single seal that has the same holding power as the fence-rated forceps in soft bipolar mode. It continuously lifts the tissue and applies continuous tension to the cutting fibers and blood vessels to smoothly perform lymph node dissection. This video shows a double soft bipolar technique in suprapancreatic lymph node dissection. First, the hepatoduodenal ligament was dissected by the Maryland forceps. After the right gastric artery was clipping and divided, the number 12A lymph node was dissected along the nerve of the proper hepatic artery. As you can see, the portal vein was identified and dissected along the vessels. Next, the right side of number 9 lymph node was mobilized and dissected from the celiac plexus, and the bottom of lymph node was sealing and cut using single seal. The cranial side of number 9 lymph node was dissected, and the dissection line was connected between the genital fascia and the fusion fascia. The dissectable layers around the left gastric artery. The artery was clipping and cut. Number 11P lymph node was dissected along the splenic artery. The splenic vein was identified as a landmark in the case. The operative time was drastically shortened, and finally 100 minutes in robotic distal gastrectomy. A single-center propensity score matched study was conducted to compare the less invasive nature of robotic gastrectomy with conventional laparoscopic surgery in the treatment of gastric cancer. The primary endpoint was postoperative morbidity. Secondary endpoint was the other operative outcomes such as operating time, intraoperative blood loss, inflammatory reactions, glomerular level, mortality, and postoperative hospital stay. Research the prospective gastric cancer database of Osaka International Cancer Institute for gastric cancer patients who underwent gastrectomy between January 2014 and December 2019. The indication of laparoscopic or robotic gastrectomy included clinically stage 1 to 4, patients with remnant stomach cancer, and patients who underwent concurrent surgery for comorbid malignant lesions, and duodenal resection for duodenal invasion or concurrent duodenal tumor were excluded. Patients with a history of abdominal surgery and oral resection for positive peritoneal lavage cytology and who had no gross peritoneal dissemination were included in this study. Besides patients who had received neoadjuvant chemotherapy and those who had undergone conversion surgery after chemotherapy for unresectable gastric cancer was included in the study. This slide shows the patient characteristics of the entire 1,189 patients and the propensity score matched cohort. The RG group comprised more male patients than the LG group. The RG group also had more advanced gastric cancer concerning tumor invasion depth, lymph node metastasis, and clinical and pathological stage compared to the LG group. Furthermore, these lymphadenectomy tend to be more common in the LG group than in the LG group. After propensity score matching, there was no statistically significant difference between the two groups in patient characteristics, including age, sex, body mass index, assay physiological status, type of tumor, type of reconstruction, and clinical TML stage. The distribution of pathological T stage, node status, and tumor stage according to the JGCC classification was similar. The operating time was significantly shorter in the RG group than in the LG group. RG equal 208 minutes, LG 231 minutes. Moreover, blood loss was less in the RG group in the LG group. According to Collabian classification, all grade complications were significantly lower in the RG group than in the LG group. There were fewer grade 3 or over complications in the RG group. There were no cases of grade 3 or higher intra-abdominal infection in the RG group, such as intra-abdominal abscess, anastomotic leakage, pancreatitis, and pancreatic fistula. There were no in-hospital mortality in the RG group. As to pancreatic injury, draining amylase levels on both 1 and 3 postoperative days in RG were significantly lower than those in LG. These results show the pancreatic injury was less in the RG group. In conclusion, robotic gastrectomy is safe and feasible in the treatment of gastric cancer with better short-term operative result in terms of shorter operative time, less blood loss, and a low rate of morbidity compared with laparoscopic gastrectomy. Robotic application in minimally invasive gastric cancer surgery have the potential to be surgical alternative. Next, I'd like to talk about single-port laparoscopic gastrectomy for gastric cancer. The application of single incision laparoscopic surgery for gastric cancer was first performed in 2009 in a previous report. Since then, some studies of pure single incision laparoscopic distal gastrectomy with D1 lymphadenectomy for the treatment of early gastric cancers have reported that it is technically feasible and offered improved cosmesis, reduced postoperative pain, and shortened recovery time. However, there are few reports on the application to D2 gastrectomy for advanced gastric cancers because it is extremely difficult to perform D2 suprapancreatic lymphadenectomy due to the limited number of access ports, restricted scope view, limited range of forceps motion, and confliction between the laparoscope and other devices. In our institute, we have standardized the placement of instruments in each operative field to prevent forceps from interfering with each other. This slide shows a representative picture of pure single-port laparoscopic gastrectomy. The picture on the right shows suprapancreatic lymph node dissection, and the picture on the left shows instrumentation placement. This slide shows the placement of a trocar into an access port at a hospital. 4 trocars are inserted into the umbilical port. The camera port should be inserted in the center of the distal side, and the 5 mm diameter trocar used by the surgeon should be inserted on both sides. A 3 mm port is inserted between the trocar for the camera and the trocar on the right side for use by the assistant. This slide shows the scene of dissection of the greater omentum. We try to create a good surgical field like a matador. Regarding the dissection of number 11P lymph node, we first dissected the dissectable layer between aorta fascia and the tooled fusion fascia on the left side of the left gastric artery. This plane is avascular and easily divided. The dissection continues posterior to the tooled fusion fascia, going laterally and coded. This sufficient separation of the lymph nodes from nerve allowed for greater mobility of the lymph nodes and facilitate the next caudal to cranial suprapancreatic lymphadenectomy. This slide is a representative photograph showing the completion of this lymph node dissection. You can see the splenic vein, a landmark at the dorsal limit of the number 11P lymph node dissection. We have reported a technical paper focusing on Belos 1 intracorporeal anastomosis using a circular stapler. We also devised a new intracorporeal triangular anastomosis intact using a linear stapler in single-port distal gastrectomy. More recently, we have reported comparative studies between single-port and multiple laparoscopic gastrectomy for gastric cancer. We conducted the propensity score matched comparative study to evaluate the feasibility and safety of single-port distal D2 gastrectomy for the treatment of relatively early gastric cancer. These results show a single-port laparoscopic gastrectomy with D2 lymphadenectomy was safe and feasible in terms of comparable operative time, less blood loss, less pain, less inflammatory reaction, and shorter hospital stay, with acceptable oncologic outcomes. There have been few comparative studies addressing the application of single-port gastrectomy for advanced gastric cancer. Therefore, we aim to demonstrate the safety and feasibility of single-port laparoscopic gastrectomy for advanced gastric cancer by comparing it with conventional multi-port laparoscopic gastrectomy. Single-port gastrectomy for advanced gastric cancer had a higher overall survival rate than multi-port gastrectomy, but the difference was not significant. In the sub-analysis by pathological stage, there was no difference between stage 2 and stage 4 gastric cancer, but the overall survival rate was slightly higher for stage 3 gastric cancer with single-port gastrectomy. We believe that the less invasive nature of single-port gastrectomy, such as less abdominal injury and a lower complication rate, is associated with better oncologic outcomes. We conducted a randomized control study to evaluate post-operative pain compared between single-port and multi-port gastrectomy. This study was published in the journal Surgical Endoscopy in 2020. The results clearly show that single-port gastrectomy is less invasive than multi-port gastrectomy in terms of less post-operative pain and shorter operative time. Therefore, this approach is one of the most attractive surgical procedures in the treatment of gastric cancer. We have been applying this single-port approach to robotic gastrectomy using the Da Vinci X-ray surgical system since October 2019. Since robotic instruments are larger than laparoscopic instruments, preventing interference between robotic arms is a challenging task. The setting and placement of the robotic instrument are standardized as in single-port laparoscopic surgery, and we have performed more than 50 single-port robotic gastrectomies for gastric cancer. I'd like to show the short video of pure single-port gastrectomy. Operative time was 180 minutes in million. There were no mobility in this series. Thank you for your kind attention.
Right, thank you, Dr. Omori. Because he is not here, we cannot have a discussion, but I can have some summary for his lecture. Interestingly, the number of open surgery is higher than minimally invasive surgery in Osaka. And since 2018, the insurance was covered for the robotic gastrectomy. The robotic gastrectomy cases were increased abruptly. And it also interestingly, in robotic gastric cancer surgery, the complication rate was lower. It's reasonable, but I'm curious that the operation time is also shorter in robotic gastrectomy. Usually, the robotic surgery has a longer operation time than laparoscopic surgery in many reports. And the pancreatic fistula rate was very lower in robotic surgery. And also interestingly, single-port laparoscopic gastrectomy is safe and feasible even for the advanced gastric cancer in Osaka. And interestingly, in stage 3 gastric cancer, the survival was better and multi-port surgery is very interesting. It needs some explanation why is that, but we cannot have a discussion. But it's probably very interesting, and in the near future we can have a discussion for this point. Okay, because of time limits, I'd like to send the moderator to Professor Liu for the next speakers.
Okay, yeah, my name is Seung from Keimyung University, Korea. I'd like to introduce the third and the fourth speaker. The next speaker is Professor Yantao Tian from National Cancer Center, China. Professor Yantao Tian is a chief surgeon at the Department of Pancreatic and Gastric Surgery, National Cancer Center, also chief of Chinese Academy of Medical Science and Peking Union Medical College, Beijing, China. Today, he will give a lecture on image-guided laparoscopic gastrectomy using ICG. Please stream the third speaker's presentation.
Dear professors and doctors, good morning. Thanks for the invitation from KCL's conference, and thanks to our conference chairman, Professor Su Huang Li, for some affairs. May I ask my assistant, Dr. Ma, to share some points of view with you. This slide is about image-guided laparoscopic gastrectomy using ICG. Well, let's start.
Good morning. I am the assistant of Professor Tian. On behalf of him, may I have this chance to share some experience of ICG navigation lymphadenectomy here by this online conference. Thank you. Here is the latest epidemiological data from Chinese Cancer Center. The table suggests that gastric cancer ranked the third place in Chinese population, especially in male. In rural area, incidence of gastric cancer has higher occupation than urban area. Possible reasons may attribute to diet behavior, lifestyle, and medical condition. Although the incidence of gastric cancer in China is showing a descending trend, we must pay attention to this disease, particularly different from Korea and Japan. Advanced gastric cancer, rather than early stage, occupied more than 50%. Therefore, in China, we not only concentrate on ICG used in sentinel node navigation surgery, but also we used ICG to guide D2 lymphadenectomy. This would be a difference, which my topic differs from Korean and Japanese surgeons researchers. With the development of equipment, laparoscopic gastrectomy and robotic gastrectomy becomes widely used in clinical practice. For its safety and feasibility are comparable with open surgeries. With the help of visual system, what we do should focus on standardization and accuracy. For standardization of radical gastrectomy for resectable gastric cancer, D2 lymph node dissection should be a guideline. However, more and more literature that showed higher number of lymph nodes harvested related to with improved long-term survival. Moreover, a two-center research from China and Japan suggested that even for node-negative gastric cancer patients, increasing number of lymph node retrieval related to improved survival. Taken guidelines of AJCC into account and literatures mentioned above, we are focusing on making navigation surgery for us to improve lymph node retrieval in gastric cancer patients. Up to now, what we used in clinical practice were methylene blue, carbon nanoparticles, ICG, etc. As a newly developed fluorescence tracer, actually not very new in view of nowadays perspective. Its characters, such as easy binding to plasma proteins, no radiation, low price make ICG popular in surgery than other navigation traces. For gastrectomy, ICG was used in mainly four aspects: labeling tumor locations, sentinel node navigation surgery, regional lymph node mapping, which was widely used in our hospital, and judging blood supply when we do anastomosis procedure. Especially, here shows a figure of one case in our department. He was diagnosed with gastric cancer. Besides, we found a single lesion in liver, which we called oligometastasis today. When we decided a gastrectomy combining with synchronous liver metastasis dissection, we used a preoperative vein injection of ICG and an endoscopic submucosal injection of ICG to show this liver metastasis and the regional lymph nodes in plant D2 area of stomach. Here lists some points which shows ICG used in lymph nodes dissection. A vital factor which influenced quality of ICG mapping lymph nodes was the method of ICG injection. In my center, we used a concentration of 1.25 milligram per milliliter solution in normal saline submucosally injected by endoscopy 12 to 24 hours before surgery. As shown in the figures on the bottom right, we injected 3 points in lesser curvature and 4 points in great curvature, with 0.5 milliliter ICG solution in each. Plates near tumor cannot be injected. However, if we plan to show sentinel lymph nodes, we used to inject 4 points around the tumor. In this case, we could only inject during the operation rather than before surgery. Recently, a Chinese surgeon, Professor Keimyung Huang, came up with a method of subserosal ICG injection under laparoscopic view. For laparoscopic distal gastrectomy in lesser curvature, he injected 3 points. One is at the interval between the first and second branch of left gastric artery, 1 point near the first branch of right gastric artery. The other point is in the middle of these 2 points. In great curvature, he also injected 3 points. One is near the first branch of left gastroepiloic artery. One is near the first branch of right gastroepiloic artery. The other point locates in the middle. For laparoscopic total gastrectomy, the injection points in the lesser curvature are the same. In great curvature, the upper point is the boundary of gastric fundus and gastric body. The lower point is the same as that in distal gastrectomy, and the last point locates in the middle. Professor Keimyung Huang registered this in the website of clinical trial. We used his method also and got nice performance. However, in my opinion, this method related to experience of surgeons, and we need to overcome a learning curve. Therefore, we expect the final conclusion of Professor Huang to see the efficiency of ICG mapping in this way. Here shows some pictures in my hospital. ICG mapping lymph nodes in great curvature and number 7 lymph nodes. Here are another type of ICG visual system which showed in lymphatic vessels and injection point in great curvature, and some other pictures. Years before, we retrospective analyzed 68 cases of advanced resectable gastric cancer. All cases underwent distal gastrectomy. The baseline of all cases enrolled had no difference in ICG group and controlled group as shown in the left table. For operation time, estimated blood loss, hospital stay, fever time, evacuation time, and incidence of complications had no statistical difference between two groups. Overall, the ICG group had higher lymph nodes retrieval. Analyzed separately, significant more lymph nodes harvested in 4SB, 6, 7, 12A, while a boundary p-value was found in 11P. However, ICG was not a metastatic lymph node specific tracer, which showed its specificity for metastatic nodes was only 10%, while its sensitivity seemed practical. I skipped the discussion part of our article, which moved to the end of my slide, because the conclusion was just questions about ICG to be identified, in my opinion. This was a prospective study conducted by Professor Huang, whom I mentioned in the section of introducing subserosal injection of ICG. His study enrolled 266 cases and 133 cases in each group, respectively. He also found an obviously increasing number of lymph nodes harvested. His conclusions supported that the safety and the feasibility of ICG. Particularly, we noticed that he compared the lymph node non-compliance rates benefit, which I would discuss later. Still, some small sample research suggested lymph nodes retrieval did not increase. As far as we know, it did exist controversy that ICG did not increase lymph nodes harvested when mapping regional lymph nodes. Some experts thought that it would not increase if the surgery named D2 lymphadenectomy. If you increase the number of lymph nodes retrieval in ICG group, it might suggest that your surgery in controlled group was not a standard D2 dissection. Therefore, I will put my opinion, which means the mechanic of ICG increasing the number of lymph nodes retrieval. The first reason would be re-examination process of ICG navigation surgery. This process helps find possible additional small lymph nodes remained in planned area, especially in the cases of high BMI or conglomerated lymph nodes in some advanced stages. I can understand what means a real D2 lymph node dissection. However, it is an ideal conception. There existed small lymph nodes which we could not easily spot it in the surgery, or after blood oozing in planned dissection area, we could not easily find small lymph nodes, etc. ICG tracer help us find those lymph nodes in this way. Second reason would attribute to its safety of ICG application. Its safety, distinguishing the boundary between the lymph nodes and the vessels, makes surgeons more aggressive in lymphadenectomy. We mentioned a conception of lymph nodes non-compliance rate just now. If more than one station of lymph nodes were not dissected, this specimen was considered lymph node non-compliance. In previous studies, lymph node non-compliance rate was used as the quality measure for D2 reticle resection during the open gastrectomy. From this table, we could see that lymph node non-compliance rate was high, even in high-volume medical centers globally. Also, in Professor Keimyung Huang's research, ICG application decreased lymph nodes non-compliance rate, which possibly standardized D2 lymphadenectomy in surgery. However, in COCT 1001 trials, the non-compliance rate in the laparoscopic group was significantly higher than that in open surgery group for clinical stage 3 disease, but no difference was found in the 3-year DFS rate between the groups. Therefore, though ICG decreased non-compliance, whether or not ICG could improve long-term prognosis depends on follow-up visits, which we do not know right now. ICG could assist in picking lymph nodes. I would move to the next part as it was not very hard to understand this part. Here lists the advantages as a brief conclusion of what I talked just now. There are questions to be identified. The first question should be why ICG increase number of lymph nodes retrieval. For option A, if we did dissect more lymph nodes than conventional due to lymphadenectomy, it may improve prognosis. However, for option B, if we had dissect a constant number of lymph nodes in the cyanide grid, only help us find more nodes from those tissues. In that case, ICG may help us improve accuracy in PTNM staging, but not improve prognosis. At the end of last year, Chinese laparoscopic gastrointestinal surgery study group initiated a multi-center prospective randomized controlled trials on clinical outcome of ICG tracer using in laparoscopic gastrectomy with lymph node dissection for gastric cancer. Its primary endpoint is 3-year disease-free survival. Now there are about 17 centers involved. This clinical trial is recruiting. The previous number of this trial was C-12, but now it changed C-11. The second question we should do is to identify the influence factor of ICG, concentration, dose, injection method, interval time between surgery and injection, BMI, etc. In my opinion, ICG relates to experience of endoscopy physicians and surgeons. Moreover, different baseline may lead to different results. However, it would be still meaningful to identify an optimal method to inject ICG. It cannot be ignored that false negative accompanied with ICG application. As tumor stage advances, occlusion of lymphatic channels are likely to happen due to the embolism of cancer cells. So the decrease of sentinel nodes was reported in advanced cases. Up to now, the accuracy of sentinel node mapping in the early stage gastric cancer is quite high. However, false negative could not be ignored, especially when we extend ICG application to advanced stages. We roughly calculated the fluorescence rate in our hospital. The fluorescence rate was satisfied. Besides, we did not observe that fluorescence rate decreased with T-stage elevating. There might be two reasons. One reason may be different ICG injection methods. We use multi-point submucosal injection under endoscopy, while tumors research use subserosal injection around the tumor. Second reason may be we inject ICG 12 to 24 hours before surgery, while tumors research inject ICG during the surgery. The interval time of ICG diffusing in lymphatic vessels was different, thereby resulted in two different fluorescence rates. In the coming days, the trend of gastrectomy might be balancing both curative treatment and function preserving. On one hand, early gastric cancer patients' occupation might be on the rise. On the other hand, surgery tends to focus on function preserving if possible. In 2008, Dr. Abe Nobutsugu from Japan used laparoscopy-assisted endoscopic full-thickness resection for an early-stage gastric cancer patient. He did a part dissection and ICG mapping sentinel lymph nodes, rather than conventional distal gastrectomy. With more similar surgeries underwent, Professor Nunove and Professor Hickey's team thought that if the sentinel lymph nodes concept is established in the surgical treatment for gastric cancer, then the indications for LECS for early gastric cancer could be expanded in the future. In 2019 KINCA conference, Professor Maruyama put his opinion on SNNS. Professor Tian was with his opinion. A cancer-specific tracer would be ideal for navigation surgery. We wish to find that on not too late future. In 2019, we invited Professor Sang-Hong An giving a lecture in Beijing. We learned a lot from him. At that time, he once invited Professor Tian attend K-Cells conference. Thanks again to our excellent Korean friends. Thank you for your attention. Due to COVID-19, Professor Tian felt sorry for absent from meeting place. If there is any discussion, please do not hesitate to contact him by email. Thank you very much. Thanks for your kind invitation.
Okay, we thank you very much for the informative presentation. As you mentioned him, unfortunately, Professor Yantao Tian could not join this live Q&A due to his schedule. The development of gastric cancer surgery in China is remarkable. We look forward to the next time we can meet together and share each other's information and friendship. Thank you again for the great skills with basic instruments, or would it better to immediately approach the new device and become more familiar with it?
Thank you for the questions. I think it is a very difficult question to me. So actually, it's two novice. I mean, unexperienced surgeons. The training kit in a DRADEC or the clinical experience. Both are very important. So my recommendation is that the novice and unexperienced surgeon should do some kind of the suturing practice in a DRADEC first, and so they have to use the anti-sensor device together. Then that they have to do the surgery. They have to use the articulated device in a clinical practice.
Okay. Yes, Keimyung-san, do you have any questions?
Oh yeah, it's very impressive to express the physics of the artificial, and I think some more advances are needed to do a safe operation, especially for the handpiece would be bulky, and the shuttle would be not comfortable, because this is very different with the robotic system. Even though the artificial can give a wider motion, but this type of instrument is uncomfortable yet. So we need more advance for this type of instrument. But your explanation or analysis for the physics was very impressive. Thank you.